What happens when the human body decides to play a trick on us?
Oh, it's a terrifying thought.
Right, like when two completely different diseases decide to disguise themselves in the exact same way.
Yeah, that is the definition of diagnostic muddy waters.
Welcome to today's deep dive, everyone. We are untangling what is essentially a, uh, a medical optical illusion today.
And getting the answer right here, it alters the entire trajectory of a patient's life.
Exactly. So imagine a patient comes in, right? And they present with these pale white patches of skin. And very often, this is in the highly sensitive genital region.
Which is already a very distressing situation for the patient.
Totally. So the doctor has to figure out, are we looking at vitiligo or are we looking at vulvar lichen sclerosus?
Right. And to figure that out, we are relying on a really robust stack of medical sources today.
Yes, including the UK National Guidelines on the Management of Vulval Conditions.
Along with the British Association of Dermatologists guidelines and some really comprehensive dermatopathology texts.
Because our mission today is to dissect how clinicians distinguish between what is essentially a benign loss of pigment and a structurally destructive disease.
Yeah, because the stakes are incredibly high. I mean, the body is waging two very different types of cellular warfare beneath the surface.
Which is wild to think about. I think we should start right at that surface, though. Like what the patient and the doctor actually see when these conditions first show up.
Because the visual similarities are really striking. Both vitiligo and lichen sclerosus, which let's just refer to it as LS today.
Good call. LS is much easier.
Right. So both vitiligo and LS present as these depigmented white patches on the skin.
And they frequently target the exact same anatomical areas.
They do. Vitiligo can appear anywhere, but it has this really strong affinity for body openings.
And LS overwhelmingly targets the anogenital region.
Exactly. And the pediatric presentation is where this overlap causes the absolute most clinical anxiety.
Wait, really? Why specifically in kids?
Well, in prepubescent girls, early stage LS often starts with just mild erythema.
So just like a slight redness.
Yeah, exactly. Just slight redness, followed very quickly by depigmentation.
Oh, I see.
And without the classic scarring that appears later in the disease, it mimics vitiligo almost perfectly.
Wow. So a misdiagnosis there would delay critical intervention for a disease that is, actually progressive.
Right, which is dangerous. But the clinical guidelines emphasize that if you look closer, the textures of these white patches diverge significantly.
Okay, let's talk about the texture. Because the texts describe vitiligo lesions as chalky white macules.
Yes. And a macule, by definition, is completely flat.
So if you were to run your finger over a patch of vitiligo with your eyes closed, you wouldn't even be able to tell where the normal skin ends and the vitiligo begins.
Exactly. There is zero textural change. It feels completely normal.
That's a huge clue.
It's a major diagnostic clue because with LS, the surface actually tells a story of the underlying damage.
Right. The guidelines describe LS lesions as porcelain white or ivory plaques.
Yeah, and more specifically, they use this really vivid term. They describe the crinkled appearance as looking like cigarette paper.
Cigarette paper. Wow. That description points directly to atrophy, doesn't it?
It does. The skin is physically thinning out, and that thinning correlates with a stark difference in physical symptoms.
Right, because vitiligo is largely asymptomatic from a sensory perspective.
Yeah.
Like, there's no itch, no pain, just the depigmentation.
But the literature constantly flags LS as being intensely symptomatic.
What are they experiencing?
Patients with LS suffer from severe pruritus. It's this itch that is notoriously worse at night.
Oh, that sounds awful. So it disrupts their sleep.
Severely. And
Yeah.
that structural thinning you mentioned earlier, it makes the skin incredibly fragile.
So it's prone to bruising.
Yeah, purpura or bruising. And these painful fissures can actually tear open just from the friction of walking.
Just from walking or wearing clothes, that's brutal.
It is. The architectural consequences of that chronic inflammation are really severe.
And vitiligo never does that, right?
Yeah.
It never alters the physical architecture of the skin or the underlying tissue.
Never. But LS acts as this destructive force. The literature documents this progressive loss of architecture in untreated LS.
Okay, what does loss of architecture actually look like in this context?
Well, we see the labia minora flattening, sometimes fusing completely with the labia majora.
Wow.
The prepuce over the clitoris can scar and seal shut, literally burying the clitoris entirely.
That's a massive structural change,
And the introitus, the opening of the vagina, can narrow significantly.
which naturally leads to severe dyspareunia or painful sex
Yes. And if the perianal area is involved, it causes painful defecation.
and chronic constipation, I imagine.
Right, which is a particularly acute problem in pediatric patients. They might associate bathroom use with severe pain and begin withholding.
That is just heartbreaking. So comparing the two visually, it's kind of like evaluating a painting. Well, vitiligo is like a painting where the color has just, faded in the sun. A canvas is fine. But lichen sclerosus is like the canvas itself is becoming brittle, warped, and literally tearing at the edges.
That is a brilliant analogy. Vitiligo is like a highly specific deletion in a biological software program.
Right. The code for pigment production is removed.
But the hardware of the skin remains entirely functional. LS, on the other hand, is a catastrophic hardware failure.
The structural matrix itself is corrupting and breaking down.
Exactly.
Okay, so that software versus hardware distinction is the perfect bridge into the underlying biology. Because if the physical manifestations are so drastically different, faded pigment versus a tearing matrix, the immune system has to be relying on totally different pathways.
Absolutely. Though literature places both under the umbrella of autoimmune diseases.
And it mentions a fascinating shared link, right? Polyautoimmunity.
Yes. Patients with either vitiligo or LS show a significantly higher frequency of having other autoimmune disorders.
Particularly thyroid dysfunction, right?
Right, which is why clinicians are strongly advised to run thyroid panels when diagnosing either condition.
Because the presence of one autoimmune disease often means there's a generalized loss of self-tolerance in the immune system.
Exactly. The body is just generally confused. But the specific antigen, the actual target of this friendly fire, differs completely between the two.
Okay, let's break that down. With vitiligo, the immune system specifically targets melanocytes.
Yes. We see these CD4 positive and CD8 positive T cells infiltrating the epidermis.
And they selectively destroy the cells responsible for producing melanin.
Right. The pigment factories are basically shut down, leaving the skin structurally sound but just totally devoid of color.
But the structural proteins are completely left alone.
Precisely. Now, in lichen sclerosus, the autoantibodies are targeting a crucial structural component instead.
Which is called extracellular matrix protein 1, or ECM1, right?
Yeah, ECM1.
And the breakdown of ECM1 is essentially a massive domino effect, because ECM1 functions as the biological glue stabilizing the structural proteins in the dermis.
Right. So when autoantibodies attack that glue, the resulting inflammation triggers the release of cytokines.
Like transforming growth factor beta, or TGF-beta.
Exactly. TGF-beta plays the leading role here. It is a master regulator of fibrosis.
So it causes scarring.
Massive scarring. When it is overexpressed due to the chronic inflammation in LS, it forces the local fibroblasts into overdrive.
And the fibroblasts are the cells that build the skin's structural scaffolding.
Yeah. Under the influence of TGF-beta, they stop producing normal, flexible collagen.
And instead, they pump out altered, abnormal collagen.
Right. And this not only results in that massive scarring, but it also damages the local microvasculature.
Oh, so the abnormal collagen actually chokes off the tiny capillaries in the dermis.
It does, which perfectly explains the fragility and the purpura, the bruising we see clinically.
Because the skin is essentially suffocating on its own overproduced scar tissue.
You're watching the supportive architecture of the skin just harden into a rigid, non-functional state.
Okay, but I have a major question here. And there's a glaring paradox regarding this systemic autoimmunity.
What's that?
If these autoantibodies and T cells are circulating systemically throughout the entire bloodstream,
Yeah.
why is the targeting so heavily localized?
Yes. The distribution.
Right, because vulvar LS has this highly specific figure-of-8 distribution wrapping around the vulva and the perianal region. And vitiligo often presents with perfect symmetry, like identical on both hands or both sides of the face.
The great question.
So why does a systemic immune response obey such strict geographical boundaries on the skin?
Well, the geographical boundaries of autoimmune skin diseases actually remain a huge area of active research.
Really, they don't know for sure.
Not definitively. For vitiligo, the symmetry suggests the immune system might be reacting to neurochemical signals.
Or tracking developmental patterns from when we were embryos.
Exactly. When melanocytes originally migrated to the skin during embryonic development, the T cells might be recognizing a specific cellular signature that is mirrored perfectly across the body's midline.
That is wild. And what about that figure-of-8 pattern in LS?
So the leading theory for LS involves the very unique microenvironment of the anogenital skin.
Okay, so the local area itself is the trigger.
Right. The fibroblasts in that specific region might have a slightly different phenotypic expression of ECM1.
Making them uniquely susceptible to those specific autoantibodies.
Yes. And you add in the local factors of chronic friction, moisture, and occlusion.
And you create an environment where the systemic weapon finds the exact lock it fits into.
Precisely. Heavily concentrated in that figure-of-8 zone.
Wow. Okay, so we have differing clinical signs and completely different pathogenic mechanisms, but clinical diagnosis has its limits, right?
Oh, absolutely. Especially in those early pediatric cases we talked about, or when atypical features are present.
So what do doctors do? The guidelines state that a biopsy becomes the ultimate tiebreaker.
Yes, we have to move from just observing the clinical phenotype to analyzing the actual histological evidence.
So biopsy is mandatory if the clinical picture is ambiguous.
Mandatory. Or if there's any suspicion of overlapping conditions or malignant changes. The pathology report provides a definitive blueprint of the cellular destruction.
Okay, so let's look at vitiligo first. It's almost like a crime scene investigation, right?
I like that.
For vitiligo, the crime is a kidnapping. The melanocyte workers are just suddenly missing from the factory.
Exactly. The pathologist is looking for a profound absence.
So the fundamental histopathological finding is just a total lack of functioning melanocytes and melanin in the basal layer of the epidermis.
Right, and pathologists rely on specific tools to confirm this absence. They use chemical stains like the Fontana-Masson stain.
What does that do?
It binds to melanin granules to make them visible under the microscope. In fully developed vitiligo, the Fontana-Masson stain is completely negative.
Those are just blank.
Yes. They also use immunohistochemistry, employing markers like melana A and HMB45.
And those markers target specific melanocyte proteins. So if the markers show nothing, it proves the cells haven't just stopped producing pigment, they have been entirely eradicated.
Eradicated from the basal layer, yes. But importantly, the surrounding epidermal structures remain totally untouched.
Right. The factory is still standing, the workers are just gone.
Exactly. Now contrast that clean eradication with a biopsy of lichen sclerosus.
Where the crime is essentially arson. The factory's structural foundation has been melted and warped.
That's a perfect way to describe it. The pathologist observes a highly destructive, very specific 3-zone pattern.
Okay, let's break down those 3 zones, because they perfectly explain the physical symptoms we discussed earlier.
Let's do it. Zone 1 is the epidermis.
Right. The texts describe orthokeratotic hyperkeratosis alongside epidermal atrophy. That is a mouthful.
It is. Orthokeratotic hyperkeratosis basically means there is a thickening of the stratum corneum, the very top layer of dead skin cells.
But without any retained nuclei in those cells.
Right. It's a hyperactive buildup of the outer shield. But directly beneath that thickened outer layer, the living epidermis is severely thinned, or atrophic.
So the normal epidermis has these undulating waves at its base called rete ridges. Right.
Yes, and they interlock with the dermis to give the skin sheer strength.
But in LS, those rete ridges are completely flattened out.
Completely flat. The epidermis just sits flat against the dermis, which perfectly explains why the skin tears so easily under friction.
It has no structural anchor.
Exactly. Now moving to zone 2, the upper dermis. This is where we see the direct result of that TGF-beta overdrive.
Right. The pathologist finds a broad band of hyalinized collagen.
Yes, and hyalinized is a critical term here.
It means the collagen has lost its normal fibrillar organized structure, doesn't it?
It does. It looks glassy, homogenized, and dense. It literally resembles melted wax under the microscope.
Melted wax. That arson analogy really holds up.
It really does. And along with that hyalinized collagen, there is a near total destruction of the normal elastic fibers in this zone.
So the skin loses all its mechanical compliance. It can't stretch anymore.
It can't stretch at all. Finally, we have zone 3, which is situated just beneath that band of hyalinized collagen.
And this is a dense band-like infiltrate of lymphocytes.
Yes. And those lymphocytes, they are the engine of the disease.
So the 3 zones present a really clear narrative. A thinned, fragile epidermal roof.
A homogenized and rigid dermal foundation.
And an active layer of inflammatory cells driving the destruction from below.
Exactly. Seeing those differing histological profiles brings us to the clinical stakes.
Because the diagnosis dictates the entire trajectory of care. Like telling the difference between missing workers and a melted foundation matters so much.
It matters because the medical stakes are vastly different. Vitiligo does not cause physical morbidity.
Right. The primary physical risk is really just an increased susceptibility to UV damage because that protective melanin barrier is gone.
Right, so strict sun protection is required.
Oh.
But the dermatological guidelines emphasize the profound psychosocial impact of vitiligo.
Because it frequently depigments highly visible areas, like the face and hands.
Yes. It carries a massive psychological burden. Patients experience severe social anxiety, stigmatization, and a notable decrease in quality of life.
So the psychological management is just as critical as the dermatological treatment.
The impact on mental health requires aggressive and compassionate intervention. Absolutely.
The physical pathology of vulvar lichen sclerosus introduces a completely different category of risk.
Yes. LS carries significant progressive physical morbidity.
Beyond the lifelong discomfort and the irreversible anatomical scarring we talked about, there is a roughly 4 to 5% risk of the LS lesions developing into squamous cell carcinoma.
Which is a highly aggressive vulvar cancer.
And the mechanism behind that cancer risk is tied directly to the structural damage, isn't it?
It is. The chronic inflammation, the continuous destruction of the extracellular matrix.
And the constant rapid cellular turnover required to try and repair that fissured skin.
Right. It creates a highly volatile microenvironment. It's essentially the perfect storm for malignant mutations to take hold in the squamous cells.
So this is why the therapeutic goals for these two conditions diverge so sharply.
Right. For vitiligo, the aim is to suppress the localized immune response and coax melanocytes from the hair follicles back into the depigmented epidermis.
And the treatments leverage phototherapy for that, specifically narrowband UVB light, which stimulates melanocyte migration.
Yes. Clinicians also utilize topical calcineurin inhibitors to calm the local T-cell activity.
The literature also highlights the efficacy of newer targeted therapies, like topical JK inhibitors, specifically ruxolitinib.
Yeah, JAK inhibitors represent a massive leap forward.
How do they work?
They work by blocking the Janus kinase signaling pathways inside the cells.
Okay, so by interrupting the specific cytokine signals that tell the immune system to attack the melanocytes.
Exactly. They allow the skin to stabilize and repigment without needing to use broad-spectrum immunosuppressants.
That's amazing. The strategy for LS, however, is not about repigmentation at all.
Not at all. It is about halting the structural destruction and mitigating that squamous cell carcinoma risk.
So what's the gold standard there?
The first-line treatment for vulvar LS is the aggressive application of ultra-potent topical corticosteroids.
With clobetasol propionate being the primary agent.
Yes. And the guidelines are very specific about the formulation, too. They recommend an ointment base rather than a cream.
Why is that?
Well, anogenital skin, especially when it's already compromised by LS, is incredibly reactive.
Oh, and creams require preservatives and stabilizers to maintain their water and oil emulsion.
Right, and those additives frequently cause contact dermatitis.
Ointments, on the other hand, are essentially pure lipid bases.
Exactly, eliminating the need for those irritating preservatives.
It's a critical nuance for patient compliance, really, because if the treatment burns due to a preservative allergy, the patient's just going to stop using it.
And then the LS progresses.
Right. Now, the guidelines outline a regimen starting with daily application, then tapering down. But they emphasize a concept that honestly can be super jarring for patients.
The requirement for lifelong maintenance therapy.
Yeah. Like, wait, so if I have LS, I have to use ultra-potent steroids forever, even when I feel totally fine.
Yes, even when the patient is completely asymptomatic, no itch, no visible inflammation, no fissures, the ultrapotent steroids must be continued indefinitely.
Typically once or twice a week, right?
Right. Lifelong maintenance is the most difficult hurdle in LS management.
Because when the itch stops and the skin looks calm, the natural human instinct is to just stop taking the medication.
Of course it is. But the inflammatory engine, those lymphocytes in zone 3 of the biopsy, is always simmering just beneath the surface.
So consistent long-term application of ultrapotent steroids is the only proven method to halt the progressive architectural loss.
Yes, and to significantly suppress the risk of malignant transformation.
The therapy literally must outlast the visible symptoms because the cellular mechanisms of the disease never truly turn off.
Exactly. And in cases where significant architectural loss has already occurred, like severe introital narrowing or clitoral burying,
surgical intervention might be necessary to restore function and relieve pain.
But, and this is crucial, surgery only addresses the physical scarring. It does not alter the underlying autoimmune process.
Right. The local inflammation will just return and destroy the surgical repairs unless the topical steroid maintenance is strictly adhered to postoperatively. Okay, so zooming out, we've taken two conditions that present identical surface illusions and mapped their completely diverging realities.
It's quite a contrast.
It is. One is a targeted disruption of pigment production, a pigment thief, basically. It carries a heavy psychosocial weight, but leaves the physical structure untouched.
And the other is an aggressive, localized breakdown of the skin's structural matrix, a structural bulldozer.
Requiring relentless management to prevent anatomical destruction and cancer.
Getting the right diagnosis isn't just about naming the condition. It dictates everything that happens next.
The clinical surface really is just the beginning of the diagnostic process. The skin is a highly complex immune organ, and its pathologies require us to look way past the visible spectrum.
And, the literature on both vitiligo and lichen sclerosus points to a final phenomenon that perfectly illustrates how deeply interconnected the skin is with the immune system.
Oh, you're referring to the Koebner phenomenon.
Yes. Both conditions can actually be triggered or exacerbated by the Koebner phenomenon.
This occurs when new lesions develop precisely at the site of localized mechanical trauma, for example.
Exactly. A patient might sustain a scratch, a minor surgical incision, or even experience chronic friction from tight clothing.
And a new patch of vitiligo or LS will erupt following the exact lines of that injury.
It bridges the gap between mechanical force and autoimmune targeting.
Which is wild. Why does physical trauma translate into a chemical signal that summons circulating autoantibodies to that exact location?
It forces us to reconsider the skin's role entirely. It isn't just a passive barrier.
To hold a localized memory.
Right. They are capable of translating mechanical stress into inflammatory cytokine cascades that actively pull the systemic immune response out of the bloodstream and directly into the tissue.
The physical injury basically acts as a beacon for the immune system's friendly fire.
It suggests a level of localized cellular communication that we are really only beginning to decode.
Which is a profound thought to leave off on. Our skin holds a deeply complex, localized memory. That's our deep dive for today. Keep wondering, keep questioning. We'll see you next time.